Okay friends, good evening. Today we have the second lecture on cardiology and we'll be discussing about cardiac electrophysiology and very basic introduction to arrhythmias. We'll not be touching individual arrhythmias, we'll be just touching about the mechanisms of arrhythmias, and in next lecture we'll be talking about individual arrhythmias, how to diagnose each arrhythmia by looking at the ECG, and about the basic treatment of each arrhythmia. So in heart there is a phenomenon known as automaticity. Means even if the heart is not innervated by a sympathetic or parasympathetic system, it can generate its own action potential, and that's the beauty of heart. In heart we have two types of cells. One type of cell is known as nodal cells, which have automaticity, and other type of cell is known as contractile cells. In nodal cells we have SA node, AV node, bundle of His, bundle branches, and Purkinje fibers, whereas in contractile cells we have actin, myosin, troponin, and tropomyosin. I have made two pictures. This picture is of a nodal cell. Say for example this is an SA node, and we have a contractile cell which are connected by gap junctions. These are known as gap junctions. Each nodal cell is connected to each nodal cell by gap junction, and each nodal cell is connected to contractile cell by again a gap junction, and each contractile cell is again further connected with other contractile cells with a gap junction. So gap junctions, they allow passive movement of cations from this cell to the other cell fast, right? These are the connections known as desmosomes. Whenever there is cardiac stretching, to prevent overstretching of the cells from each other, so as to not to disrupt the gap junctions, we have desmosomes. So a combination of desmosomes and gap junction is known as intercalated disc. Intercalated disc. So the function of intercalated disc is that it prevents gap junctions to move away from each other. So they remain closely, tightly bound to each other. Now if we talk of nodal cells, say for example this is an SA node, it starts firing. How does it start firing? How does the initial start of action potential takes place? So there is a funny channel known as funny or leaky sodium channel. What happens is there is slow leak of sodium from outside to inside in the SA node. So here we have a graph, right, where we'll be plotting the action potential curve. So this will be millivolt, and this will be time, this will be millivolt, this will be time. Here I'll be plotting the graph of a nodal cell, and here I'll be plotting the graph of a contractile cell. This is resting membrane potential, this is threshold potential. Resting membrane potential and threshold potential. Now you just have to visualize one thing, that resting membrane potential of nodal cell is not stable. Resting membrane potential of a nodal cell is unstable, means there is a constant leakage of sodium from outside to inside. So we have a resting membrane potential in a nodal cell which is say around minus 60 millivolt. Now there is a slow leakage of sodium, so there is a influx of positive ions inside. So nodal cell will become less negative. From minus 60 it will start becoming slightly positive. So say example, this is the sodium which is going in. As soon as it reaches minus 55 millivolt, what happens is there are two types of calcium channel, T-type calcium channel and L-type calcium channel. So there is sudden opening of T-type calcium channel at minus 55 millivolts. So calcium starts coming in. So at 60, sodium is coming in. The moment it touches 55, T-type calcium channel opens and calcium starts coming in from outside towards inside. This is the part of calcium. This was sodium. And the moment it touches minus 40 millivolt, L-type calcium channel opens. This L-type calcium channel, it inpours calcium fast. Very fast they import the calcium. Suddenly the action potential, it shoots up like anything, right? And it shoots up to plus 40. Whole of the interior of nodal cell or SA node becomes positive, 40. So there is sodium and calcium inside the nodal cell, which is making itself depolarized. So the cell is fully depolarized now, right? With the help of leaky sodium channels, T-type calcium channels and L-type calcium channel. At minus 60, sodium is leaking in. At minus 55, T-types open. At minus 40, L-type open, and the action potential rushes up to plus 40 millivolts. Now what happens is, these sodium and calcium ions, they pass through the gap junctions to the contractile cell. Sodium and calcium. So the contractile cell, its resting membrane potential is minus 90. This is fixed. It's not varying. Okay, contractile cell will contract and then it will relax. It will contract, then it will relax. So its action potential is fixed, right? So what happens is, as sodium and calcium starts going into the contractile cells, its resting membrane potential starts rising. So it rises from minus 90 to minus 70. So there is a rise because of sodium and calcium, which is coming in from the nodal cell. Getting the point? So nodal cells are outpouring their calcium and sodium through the gap junctions into the contractile cells, and in the contractile cells the resting membrane potential rises from minus 90 and goes to 70, which is the threshold potential. Here at the threshold potential, sodium channels open up. Voltage gated sodium channels, they open up, and sodium starts coming in fast, and there is a rise of action potential. But it doesn't rise as action potential rises in nodal cell. It rises up to plus 10 only. This is due to voltage gated sodium. The moment voltage gated sodium channels open and action potential reaches to 10 millivolts, these shut down immediately. It stops. The moment it stops, there is a bit of fall like this, and we have outflow of potassium ions. The moment action potential reaches 10 millivolt, we have abrupt shutdown of voltage gated sodium channels and the opening of potassium channels from inside to outside. So what will happen? The action potential will fall from 10 to 0. Okay, so there is a dip in the action potential, and now L-type calcium channel opens. Calcium is coming in fast. So there are two things happening now. We have calcium coming in and we have potassium leaving out. So net outflow, net balance is 0. So it stays at isoelectric line like this. So for around 250 milliseconds, there is no net gain or loss of charge. Calcium is coming in, potassium is going out. There is sarcoplasmic reticulum inside the contractile cell which contains lots and lots of calcium. Abundant of calcium is there in sarcoplasmic reticulum. So there is a stimulus from this calcium to open up this calcium from sarcoplasmic reticulum, and calcium starts coming in. Actin and myosin, they interact and there is a contraction, right? Because of this calcium which is coming in, it's a stimulus for outpouring of calcium from sarcoplasmic reticulum, and this abundant calcium causes contraction between actin and myosin. Actin, myosin, they interact and cell contract, right? At that very moment, in this cell, potassium starts leaving in, out. The moment potassium starts leaving out, the action potential falls like this. Potassium is going out. Okay? Potassium is going out, action potential falls to -60. Again here, you have the moment 250 milliseconds have elapsed, contraction has occurred, calcium starts going in against the concentration gradient. So there is a use of ATP here. ATP is used, proton is exchanged. So calcium goes against the concentration gradient, contraction ceases. Because if there is continuous outpouring of calcium, the cells will remain in tetany. So they have to relax. To relax, ATP is being used, right? Calcium goes into the sarcoplasmic reticulum, hydrogen ion is exchanged, and this calcium intake goes down. So here the action potential starts going down like this and stays like this for some time. Potassium is continuously moving out. So here this is potassium moving out. So by and large, if we compare, potassium is helping in reaching both cells to resting membrane potential. Calcium and sodium, they are trying to make cells reach the threshold potential and to the maximum action potential. Potassium is helping in relaxation, right? Why? I hope this is clear, right? The basic fundamental point is clear, right? How the ion exchange is taking place between the nodal cell and contractile cell, and what is the basic mechanism of the cardiac cell contraction, and how the action potentials are being generated. Why this graph is important is when we will be looking tachyarrhythmias, the pathophysiology of tachyarrhythmias contain a word known as trigger activity. When you have trigger activity, I'll come to that, you have two terms known as delayed after depolarization and early after depolarization. If you don't know this graph, you will never be able to understand this thing. And this is very, very, very important when we are talking of VTach, when we are talking of other tachyarrhythmias. What is delayed after depolarization? Delayed after depolarization means, suppose this is a cell, right? A contractile cell. Action potential is like this. Because of something, say for example, we have MI, patient is hypoxic, or there is something else going on, right? So this cell is irritated. So as soon as it starts going down, there is some problem here, there is again action potential like this. There is again action potential like this. Again action potential like this. So this is known as delayed after depolarization, right? Sorry, this is known as early after depolarization, EAD. This is the depolarization graph, and this is the early after depolarization. Similarly, if these action potentials, they start from here like this, like this, like this, this is known as delayed after depolarization. So it means that problem is not with the nodal cells, problem is with the contractile cells, right? In certain type of arrhythmias, there is early after depolarization and there is delayed after depolarization. Okay. In last lecture, we understood the fact that AV node acts as a guard. It holds the charge for 0.1 second. The reason of holding the charge is that if it wouldn't have holded the charge, atria and ventricles would have contracted simultaneously. It is giving time to the atria to contract its last bit of blood into the ventricles. Okay. And that is the reason of holding the charge. Otherwise, atria would have been contracting and ventricles will also be contracting. So it goes against our common sense. The second point is that you have receptors, beta adrenergic receptors and acetylcholine receptors. You know, beta adrenergic receptors and acetylcholine receptors, they innervate nodal cells, but contractile cell is not innervated by acetylcholine receptors. So beta adrenergic receptors, they are there on nodal cells as well as on contractile cells, but acetylcholine, by virtue of parasympathetic system, it acts only on nodal cells. Now I'll come to arrhythmias. I hope this basic electrophysiology is absolutely clear, right? So if you want to define arrhythmias, so arrhythmia is something wherein you have problem in rate, rhythm, conduction or origin of electrical impulse. So there are 4 things which we need to learn. So there is abnormality in rate, rhythm, sequence of conduction, or origin of impulse. Any problem anywhere will give rise to arrhythmia, right? The normal heart rate is 60 to 100. Anything above 100 is tachycardia. Anything less than 60 is bradycardia. Right? So, if we talk about classification of arrhythmia, classification is either you have Brady arrhythmia or you have tachyarrhythmia. In Brady arrhythmia, either you have sinus bradycardia or you have first degree AV block, you have second degree, which is of 2 types, type 1 Mobitz, type 2 Mobitz, and third is third degree AV block. The other type is Tachy syndrome or 6 sinus syndrome. 6 sinus syndrome, also known as Tachy syndrome. You know what is happening is 6 sinus syndrome. The sinus node is dysfunctional, right? So the rate is slow. some other pacemaker in the atria, it takes over its role, and there is tachycardia. So there is alternate bradycardia and tachycardia. This is known as Tachy-Brady syndrome, also known as sick sinus syndrome. If we classify tachyarrhythmia, it can be of two types: supraventricular and ventricular. In supraventricular, you have sinus tachycardia, you have focal atrial tachycardia, also known as FAT. Then you have multifocal atrial tachycardia, you have atrial fibrillation, you have atrial flutter, you have SVT. In SVT you have two types: AVRT, AV reentrant tachycardia, and AVNRT, AV nodal reentrant tachycardia. Right? In ventricular, you have ventricular tachycardia, which is either monomorphic, means the morphology of the abnormal beats is exactly the same, or it is polymorphic. In polymorphic, it can be of two types: with normal QT interval or with prolonged QT interval, which is known as torsade points. Right? And second is ventricular fibrillation, VFib. Alright, so this is the basic classification. You have Brady arrhythmia, in which you have sinus bradycardia, then you have first degree AV block, second degree, which is of two types: type 1 Mobitz, type 2 Mobitz, third degree AV block, then you have sick sinus syndrome. In tachyarrhythmias, you have supraventricular and ventricular, sinus tachycardia, FAT, MAT, AFib, atrial flutter, SVT, which is of two types. In ventricular, you have VTAC, which is monomorphic or polymorphic. Polymorphic would be of normal QT interval or a prolonged QT interval, or VFib. You will find other terminologies also. Say you will find terminology as AFib with aberrancy. That doesn't mean something new. It means atrial fibrillation is the rhythm, but you have a bundle branch block. You may be having left bundle branch block, so morphology will differ. You can have SVT with aberrancy, means there is some other tract by which supraventricular impulses are passing through, so the QRS complexes, they vary. We'll try to differentiate it. There are finer points how to differentiate these aspects, but this is the basic we should always remember. Now if we'll start with the mechanisms now, and you please pay attention, because mechanisms of arrhythmias are very important. We'll start with Brady arrhythmias first. Brady arrhythmias. Brady arrhythmia can occur because of two causes. Either there is a problem in automaticity, or there is a problem in conduction. Simple. So you have decreased automaticity or decreased in conduction, or rather conduction block. So decrease in automaticity can be physiological. Say for example, you are an athlete, so you have a physiologically low heart rate, right? So it can be physiological. Such as in athletes. There can be states where your metabolic rate is slow. Say for example, hypothermia, decreased BMR. So hypothermia. Or you have low TSH, high TSH, hypothyroidism, myxedemic coma. You have bradycardia because of decreased automaticity. You have increased intracranial tension, known as Cushing's reflex. Right? You have inferior wall MI, which affects your SA nodal automaticity, because RCA supplies SA node, right? So there is decreased blood supply to SA node, the automaticity goes down, right? Then you have certain drugs such as beta blockers, calcium channel blockers, digoxin, right? And last but not the least, hyperkalemia. So these are the factors which affect automaticity. Automaticity decreases and you have bradycardia or Brady arrhythmias. So physiological in athletes, decreased basal metabolic rate, which is hypothermia, or increase in thyroid hormone, myxedema, increase ICT as a part of Cushing's reflex, inferior wall MI, a patient who is on beta blockers, calcium channel blockers and digoxin, and patient who has hyperkalemia, right? Now you have conduction blocks. In conduction blocks, again, it can be because of some disease per se of the conduction system. Now there are two types of conduction system. If we draw atria like this, right atrium, left atrium, this is your SA node, this is your AV node. So there is a tract known as Bachmann's bundle, which conducts impulse from SA node to left atrium, and this goes down like this towards AV node. In right atrium we have internodal pathways. So SA node through internodal pathways, it goes towards AV node. So you can have problems in these bundles per se. So there can be fibrosis or scarring, old atrial MI scar, right? You can have infiltrations, say for example sarcoidosis, amyloidosis, right? Again, potassium can give rise to conduction block. Drugs such as beta blockers, calcium channel blockers and digoxin, they give rise to conduction blocks. So this is the basic, mechanism of Brady arrhythmias, decreased automaticity and conduction block. Now we'll talk about tachyarrhythmias. If we talk about tachyarrhythmias, we have three mechanisms. One is increase automaticity, second is trigger activity, and third is reentrant circuits. Now increased automaticity can be because of, say, low blood volume, hypovolemia. Hypovolemia will cause reflex tachycardia. So automaticity increases, right? You have anxiety, you have fever, right? So you are taking some stimulants, you are taking some sympathomimetics. You have thyrotoxicosis. So all these will result into increased automaticity, thereby giving rise to any of the tachyarrhythmias. Now trigger activity, as we discussed earlier, this is your resting membrane potential, this is your threshold potential. The graph goes like this, down, plateau, goes down like this. You must have read in your physiology about phases of action potential, right? This contractile cell resting state is 4 here. When potassium is going out, this is 3. This plateau is 2. This is 1. This is 0. Okay? This is for contractile cell. This is not for nodal cell. For a contractile cell, this 4 is the resting membrane potential, 3 is the downslope where potassium is going out, 2 is where calcium is coming in, potassium is going out, 1 is where sodium channels stopped abruptly and potassium started outpouring, and 0 is voltage gated sodium channels. So whenever there is any problem in the cell, it gets triggered. The triggering factor could be early, which is known as early after depolarization, or it can be late, known as delayed after depolarization. So early after depolarization, delayed after depolarization. This early after depolarization is very important. This is the mechanism behind Torsade points, that is polymorphic VT with prolonged QT interval. So mechanism of Torsade points is early after depolarization, and the basic problems is with potassium, calcium and magnesium here. So what is happening is, either you have low potassium, or you have low calcium, or you have low magnesium, which will precipitate in a susceptible individual Torsade points. And that's why we use correction of potassium, correction of magnesium as a treatment of polymorphic VT with prolonged QT interval, right? Everyone who has tendency to develop TDP will not get TDP unless the situation is conducive. Situation becomes conducive the moment there is low potassium, there is low calcium, there is low magnesium, right? Now there are certain situations where TDP or Torsade points or polymorphic VT with prolonged QT interval can be precipitated apart from this. So it can be antiarrhythmic use. Drugs, antiarrhythmics in special situations can produce polymorphic VT with prolonged QT interval, particularly class 1A, 1C and 3. Class 1A, 1C and 3 in a patient who has prolonged QT interval with low potassium can trigger TDP. Second, certain antibiotics such as macrolides. You must have heard clarithromycin. Clarithromycin with a red box warning that it can precipitate polymorphic VT, right? Then you have antipsychotics such as haloperidol. Then you have antidepressants, particularly tricyclic antidepressants, and you have antiemetics. Very important. Ondansetron. This drug we use left and right, particularly in patients who are going for pre-op surgeries. We use AMSIT. With AMSIT, you can land up into bradycardia, and you can land up into polymorphic VT. We should be very much aware of QT interval if we are using it, particularly in a cardiac patient who is undergoing surgery. So we need to see the QT interval before giving this, simplest of drug which we are using left and right. So class 1A, 1C and 3 type of antiarrhythmics, macrolide group of antibiotics, antipsychotics such as haloperidol, antidepressants such as tricyclic antidepressants, and antiemetic ondansetron. They are implicated in EAD, which goes in the favor of polymorphic VT with prolonged QT interval. If I talk of DAD, delayed after depolarization. So what happens in DAD is it can happen in myocarditis, it can happen in myocardial infarction, it can happen in mitral regurgitation where there is enlarged LV, it can happen in hypoxia, it can happen in digitalis overdose or digoxin overdose, or you can have dilated cardiomyopathy. So the mnemonic can be, you have 2D here, so D2 M3 H, DAD, D2 digitalis, dilated cardiomyopathy, myocarditis, MI-MR and hypoxia. These are implicated in development of DAD. And how does DAD affects? It affects in development of tachyarrhythmias. I hope this is clear, right? Now we'll come to reentrant. Just pay attention to reentrant. This will be the last thing which we'll be talking in this lecture. It's very important. Reentrant circuits. The name itself is suggestive that you have SA node, you have AV node, you have bundle of His, and you have left bundle, right bundle. So this is a common pathway. The problem is that apart from AV node, rest everything atrioventricular junction is electrically inert. Electrical impulses cannot pass from atria to ventricles apart from AV node. They can only pass through AV node. But there are certain abnormalities. There can be a tract which is accessory tract known as bundle of Kent. Bundle of Kent. Bundle of Kent differs from AV node. See, AV node has an intrinsic property of holding the charge. It acts as a guard. It's helping the heart. This won't. This is bidirectional. Bidirectional means the flow of charge can be this way or it can be this way. Right? So bundle of Kent is an accessory pathway where flow of charge is bidirectional and it's fast. It won't hold the charge like AV node. And this bundle of Kent is implicated in development of Wolff-Parkinson's White syndrome, WPW. Right? So reentrant circuits, they are generally implicated in development of SVT, that is AVRT or AVNRT, in atrial fibrillation, atrial flutter, VTAC, VFib. These reentrant circuits can be at the junction of, AV junction or atrioventricular junction, anywhere It can be in the muscles also, small reentrant circuits. In the ventricular muscle, you can have small circuits. Suppose you have an inferior wall MI. So there is a tissue which is scarred, but it is electrically active. So there can be a reentrant circuit, local reentrant circuit. So it can be circuit here, it can be here, it can be here, it can be in the atria, it can be anywhere, right? So how does SVT, where we have AVRT and AV and RT differs? Here in AV and RT, the reentrant circuit is in AV node. In AVRT, the reentrant circuit is away from AV node, right? Clear? AV and RT means the reentrant circuit is in the AV node, and AVRT you have reentrant circuit which is far away from AV node. This is the AV node which I am drawing, right? So just imagine that this right side tract, it got fibrosed for any reason. There is some fibrosis, right? This is a normal tract, but it got fibrosed. Just imagine this for the sake of argument. So we say it as alpha pathway. This is a beta pathway, right? Alpha pathway is slow, beta pathway is fast. A slow pathway has a long refractory period. A beta pathway has, slow pathway has short refractory period. S for short. Fast pathway has a long refractory period. Now just imagine that the impulse starts traveling from SA node. It comes here, goes to both part. Here it encounters resistance. Because of some problem. So the passage will be delayed. It's a fast path. Goes like this, goes down and goes up. But both will cancel. So you have a normal right bundle, left bundle, which goes down. Because the conduction is fast, PR will be shortened. Got the point? The moment it goes here, you will have QRS. Impulse, if it goes like this slowly, PR will be normal. Now here there is a problem. So impulse chooses the fast path, goes fast, PR gets shortened. Right? Now imagine that again second impulse comes, encounters resistance here. It is only encountering resistance because it has a short refractory period, so it is open for conduction. But this beta fast pathway has a long refractory period. It is not open for conduction, so it will pass, though slowly, from this. It is passing slowly. Meanwhile, it reaches here. This beta pathway, beta gets, awakened up. Its refractory period is over. The impulse travels down and goes up to like this. Getting the point? When impulse is coming from up, it is encountering this fast pathway in refractory period. So it goes through the slow pathway which is out of the refractory period. The moment impulse reaches down, this fast pathway is out of its refractory period. So impulse goes down and up like this. Right? The moment it goes up here, this pathway gets out of its refractory period, and then there is a cycle. One goes up, one goes down, cycle. One goes up, one goes down. This is the mechanism of SVT. When it goes like this, the P wave goes away. In SVT, you don't find P wave. Even if you find P wave, either it will be hidden in the QRS, or there will be slight inverted P wave after QRS. We'll come to this after in our next lecture, when we'll be classifying arrhythmias on the basis of ECG identification parameters. This is clear, right? So you have a tract which is diseased, it's slow, impulse will take fast pathway, it will go up, but they will get cancelled. The second impulse will come down, it will encounter a fast pathway which will be in the refractory period, it will travel down the slow pathway. By the time it reaches down, this fast pathway would have recovered from its refractory period. This impulse will go up into the atria, and again it will pass through this circle, and this loop will start into a vicious cycle, and SVT will start, right? So this is how you understand reentrant circuit. So we'll stop here. Will not go into depth of arrhythmias. In this class, the objective was just to understand the basic electrophysiology of heart, the classification of arrhythmias, the basic mechanisms by which arrhythmias originate, Brady arrhythmias and tachyarrhythmias. And in next class, we will be doing ECG identification parameters of all ECGs, all Brady arrhythmias, all tachyarrhythmias, and we'll try to cover the medical management, long-term treatment, and surgical management of arrhythmias. Right? Thank you very much.